Good afternoon. I am Dr. Gulshant Panesar. I am Assistant Professor Dermatology, Santosh Medical College. Today's lecture is on scabies. Scabies, I will be speaking about the introduction to the disease, the microbiology and life cycle of the scabies mite, the epidemiology, the pathophysiology and clinical features, the clinical variants, the complications, investigations and the management of scabies, and I'll also enumerate the crusted scabies. So scabies is a parasitic infestation of the skin. It is an ectoparasite. It's known as, it's caused by a mite called a Sarcoptes scabiei variety hominis or Sarcoptes scabiei var hominis. The infection results by a complex interaction between the host, the parasite and the associated microbiomes. The microbiology of the Sarcoptes scabiei and its life cycle. The body of the mite is creamy white, transverse corrugations and bristles and spines on the dorsal surface. 4 pairs of short legs are there. Anterior 2 pairs end in elongated peduncles tipped with small suckers to attach. So adult female is 0.4 millimeter long and 0.3 millimeter broad, and the rear 2 pairs of legs end in long bristles which are known as setae in females. The adult male is slightly smaller. It is 0.2 millimeter long into 0.15 millimeter broad, and bristles are present on the 3rd pair and peduncles with suckers are present on the 4th. The life cycle is completed entirely on human skin. The male-female copulation happens and the female forms burrows in the stratum corneum to the boundary of stratum granulosum. The burrows are fine, tortuous, blackish threads a few millimeters long, and approximately 40 to 50 eggs are laid by each female in a lifespan of 4 to 6 weeks. Male mite lives on the surface of the skin, enters burrow only to procreate. Average number of adult female mites on an individual is 12. So the life cycle is the egg is laid in the burrow, it hatches and it releases larvae. The larvae molt into nymph, and then larvae and nymphs are found in short burrows called molting pouches. 2 moltings happen. After that, mating occurs after the male penetrates the molting pouch of the adult female. It impregnates the females, extend their molting pouches into burrows, laying eggs, and adult females deposit eggs as they burrow. So this is how the life cycle of the Sarcoptes scabiei is, and transmission of the disease happens by person to person contact and fomites like bedding and clothing, and infective stage is the female mite laying the eggs. So the most common location of mites is on the ulnar border of the hand, the wrist, it's known as the inverted triangle of Hebra, the popliteal fossae, the knee joints, the perineal area and the axilla, and as well as the mammary area. Epidemiology, there are 100 to 300 million people worldwide. The infection is also transformed by social attitudes, the population movements, malnutrition, lack of access to healthcare. So the disease is more seen in the 3rd world countries. Inadequate treatment and deficient hygiene. Age, it can affect all age groups. It is frequent in elderly or the extremes of age because of poor attention to the hygiene or a poor immune status. It is common in conditions of overcrowding like hostels and prisons or nursing homes. Sex ratio, it can affect equally the males and the females. It's equally common in all ethnic groups, and customs and social factors also facilitate infection. There is no inherent susceptibility. It is transmitted by close physical contact. Outside the host, the mite can just survive for 24 to 36 hours at room temp conditions. Allergic sensitivity to the mites or its products is important in development of the lesions and pruritus. And there is both immediate as well as delayed hypersensitivity to the mite. So clinical features, the most common clinical features is itching, and usually in a classic scabies, the face is spared. The itching is characterized, it is one of the most severely itchy conditions of the skin, and it is characterized by worst itching at night. It occurs 3 to 4 weeks after acquiring the infection. The burrows are seen as slightly raised brownish tortuous lesions in the interdigital clefts, and small erythematous excoriated papules can be seen in the umbilicus in the genital area. Inflammatory pruritic papules or nodules on the male genitalia are characteristic, and excoriations and eczematization and impetiginization or secondary infection can happen. So the common sites are nipple, areola, anterior axillary fold, elbow, flexure, wrist, web spaces, genitals, umbilicus. These are the common sites infected. And itchy nodules persist for several months after successful treatment also at times, and nodular scabies or persistent scabitic nodules can be seen due to response to persistent scabies antigens. So in infants, there is a little difference between the adult scabies infection and the infants. In infants, a head and neck is involved, whereas in adult scabies, a head and neck is usually not involved. And vesicles also can be seen. Vesicles and vesiculopustular lesions are seen on hands and feet. Even the palms and soles are involved. And extensive eczematization can be seen in infants. In elderly also, there are burrows on palms and soles, and truncal papular squamous lesions can also be seen, often surmounted by burrows even on the trunk. So complications can be eczematous changes, and if the treatment is done by steroids, there can be scabies incognito. There can be secondary infection by staph or strep causing folliculitis or impetigo. And in tropics and subtropics, if the secondary infection by staph is by a nephrogenic strain, or by strep, it is by beta hemolytic strep, it can cause glomerulonephritis. On microscopic examination, it's done by slight scraping of the burrow and mounting it on the slide. Mites and eggs or fragments of eggshells or scibilla can be seen. Even on dermoscopy and 40x magnification, mite in its burrow resembling a jet with contrail can be seen, and in 10x magnification, circumflex accent-like image, head and 2 pairs of front legs of the mite can be seen. Adhesive tape test is also one of the methods to diagnose, wherein the tape is fixed to the burrow, and then the tape is lifted, and the tape is examined under the microscope, and the burrow or the impression of the mite or the impression of the mite is seen. So in skin biopsy, at times skin biopsy may be required. Usually the diagnosis is almost 99.9% clinical, but at times skin biopsy may be required. Then mite or parts may be identified in the skin biopsy. Non-specific features like in the histopathology are epidermal spongiosis, papillary edema, and inflammatory cell infiltrates with numerous eosinophils. So how do we manage scabies? The most important thing is the patient as well as other family members. All the family members should be treated, whether they show symptoms or they don't show symptoms. So treat close physical contacts even without pruritus or cutaneous lesions. Patient education is very important. Avoid close physical contact. Personal hygiene, the patient should be counseled for. All household and close contacts should be treated simultaneously, not sequentially, and combination of a scabicide and fomite control. Topical treatment is by permethrin, lindane, benzyl benzoate, crotameton, or precipitated sulfur. Permethrin, the mechanism of action is that it acts on the nerve cell membrane, disrupts sodium channel current. It causes delayed repolarization and paralysis and death of the mite. A second application can be done usually a week after the initial treatment. The permethrin is used as a 5% lotion. It should be applied from chin down to whole body surface area, and every part of the body surface area except the face, the lotion should be painted. Then the patient, the contact time should be 6 to 8 hours. The patient can sleep off with the medication, taking in preventing the application or ingestion of the lotion, and bathe the next day and wash the clothes in hot water. So a second application can be done a week later. It can reduce the potential for reinfestation from the mites and kill any nymphs that may have hatched after the treatment. Oral treatment, ivermectin is usually used for oral treatment. It causes influx of chloride ions through cell membranes, again hyperpolarization and paralysis and death of mite. So lindane also is available as 1% lotion or cream. The contact time is 6 hours. Benzyl benzoate is available as 25% ointment, and it is to be applied for 24 hours and rinsed off and then again repeated. Trotameton is available as 10% ointment. It is to be rinsed off after 24 hours. Precipitated sulfur 2 to 10% in petrolatum base, and it's rinsed off after 24 hours. And ivermectin pills, it's given in 200 micrograms per kg, repeated on day 7 to 14, and it's usually given as a single dose. So if the patient is above 60 kgs or above, 12 milligram tablet is a standard dose of ivermectin, and if the patient is less than 60 milligrams, then 6 milligram is a standard dose of ivermectin. So additional measures are all clothes and bedding should be washed at night, washed at high temperature, that is greater than 60 degrees centigrade, or kept in plastic bag for up to 72 hours. Materials or fomites that can be washed where the patient is, all the fomites and materials should be disinfected or treat with insecticidal products. All clothing, pillowcases, towels and bedding used during the previous week should be washed in hot water and dried at high heat. Non-washables should be dry cleaned, ironed or stored in a sealed plastic bag in a warm area for 2 weeks. Floors, carpets, upholstery and furniture should be vacuumed. So itching can persist even despite adequate treatment for up to several weeks after the scabies mite has gone, or it's been scabicidal and the mite is dead. Even after that, itching can persist for up to 4 weeks or at times up to 6 weeks because of the hypersensitivity. So if there is concurrent secondary infection, a course of antibiotics should be given depending on the patient's weight, and usually penicillin group of antibiotics or azithromycin can be given for secondary infection. Amoxicillin clavulanic acid combination can be given. If there's too much of dryness, emollients is helpful in curbing the cutaneous irritation. Then a word about crusted scabies, or also known as Norwegian scabies. It is a rare disease. It's not very commonly seen, but it is a severely debilitating form of scabies. It is characterized by infestation of up to millions of mites. As I said before, that average number of mites is only 12 in a infected patient, but in Norwegian or crusted scabies, it is up to millions of mites, and it is characterized by development of a hyperkeratotic skin crust. So it occurs in people with an inadequate immune response to the mite, allowing them to multiply unchecked. So it is usually seen in patients who have mental retardation, dementia, Down syndrome or immunosuppression. So it is characterized by large warty crusts on hands and feet, palms and soles irregularly thickened and fissured, nail apparatus, masses of horny debris beneath thickened discolored nails, erythema, scaling on face, neck, scalp, trunk may be generalized. And itching need not be present in this form of scabies. It can be slight or maybe absent. There is usually a lymphadenopathy which can be generalized. On blood examination, there will be eosinophilia and elevated IgE levels. And if you examine the scrapings, it's teeming with mites and eggs. So such a patient needs hospitalization, and in addition to the scabicidal measures, also need keratolytic agents like salicylic acid preparation, and personal hygiene, nails to be cut short and nails also to be brushed with scabicidal agent. Topical scabicide application is repeated until 2 parasitological tests 3 days apart are negative. So it's to be repeated every week. Ivermectin may be required between 3 and 7 doses. So take home messages that human infestation caused by host specific itch mite lives its entire life cycle within the epidermis, that is the stratum corneum. is characterized by a very pruritic eruption after an incubation period of 4 to 6 weeks. It's transmitted by close physical contact or fomites. Topical therapy is the most popular therapy, can be done singly as a stat permethrin 5% lotion, or if it is severe can be repeated every week for up to 4 weeks. Oral ivermectin is also very effective. All family members and close contacts should be treated simultaneously. Thank you.